This is Dr. Leah Kaye, and you've tuned into my preoperative discussion on hysteroscopy. This will include instructions for pre-op, during your surgery, and post-op or recovery. Things that are important to know for the day of the surgery. We want you to come in the morning with having had nothing to eat or drink after midnight the night before. That includes sips of water. So, we're in Las Vegas, it's the desert. If you usually go to bed with a glass of water, avoid doing that the night before your surgery so that you don't instinctively wake up in the middle of the night and start drinking. The exception to this rule is there are some medications that people will take in the morning that we may want you to take before your surgery, including hypertension medications. So check with us before the day of your procedure. The Granite Surgical Center, which is where we do our procedure, is actually in the same building as the Fertility Center of Las Vegas. So you will come to this same location to get checked in, but you'll be pulled into a pre-op area, which is just on the other side of the waiting room. When you're there, you'll get an IV placed in the vein in your arm, and they'll give you fluids through the IV to get you rehydrated. This is actually also how we administer medications to help you fall asleep for the procedure. Before the procedure happens, you're going to meet with our surgery team. That includes our nurse who's in the pre-op post-op area, as well as our nurse anesthetist. And you will also see your doctor before anything happens so that you have a chance to ask last-minute questions. When everything is ready to go, we'll roll back to the operating room. You'll lay down on an exam room table that's just like the same ones in our ultrasound rooms. You'll fall asleep comfortable underneath blankets, and we do what's called deep sedation with some medications that help you fall asleep. It's not so deep that you're getting intubated. We're not putting any tubes down your throat. You're breathing on your own, but we will use a face mask to provide extra oxygen. And you go off to sleep. This is the best part of the entire hysteroscopy. If you've ever had deep sedation, it feels most of the time like a very restful, deep sleep, and you wake up feeling very refreshed, having no idea how long you were asleep. While you're asleep, what will happen is we then put you into stirrups, and we use a brown betadine soap to sterilize inside the vagina and on the skin outside. You might see that soap wash off when you're getting dressed or getting in the shower after the procedure. And that's to help prevent infections. With the speculum in place, we can take a little camera. It's about the size of a ballpoint pen, and we can just gently navigate it through the cervix and into your uterine cavity. At that time, we can then see directly with a lens, a camera at the very end, exactly what we might have seen or anticipated seeing on prior exams, like a sonohysterogram or water ultrasound. Here are some examples of what we might have seen and that might be prompting us to proceed with your hysteroscopy. This is an ultrasound of a uterus. This is the muscle of the uterus. This is the cervix at this end. The black is the salt water that we put in at the time of a saline infusion sonohysterogram. And you can see there's this thing that looks like a tongue sticking out in the cavity. That is a classic endometrial polyp. Polyps are not dangerous per se, but they definitely get in the way of fertility. So when we see them, we take them out. This next picture is an example of something called a uterine fibroid, which is an overgrowth of the muscle of the uterus. Many times fibroids don't make a difference for fertility, but if they come into the cavity, as this one appears to, here's your endometrium and here's the uterine fibroid coming right into it. Those are situations where we remove those as well to help you become pregnant. Here, I've put a couple pictures of what we're actually doing when the camera is inside. When we put our camera in, we put fluid through the camera to expand the cavity so we can see and we can look around in there like we're in a room. And we'll take survey of what it is to see. And here's an example of endometrial polyps coming up from the posterior wall of the cavity. Our camera has a little port where we can send instruments through, like scissors, and we can take those scissors to just snip away what doesn't belong inside there. And we can then put graspers in to pull things out. Here's an example of a little fibroid, a submucosal fibroid poking up in from the posterior wall. Here's a picture of something that you can't see on our ultrasounds. You can only see it with hysteroscopy. It's called chronic endometritis. So that's a low-grade inflammation of the endometrium. And it looks like these little irregular bumps, some things we call micropolyps, as well as this redness and these dilated blood vessels throughout the cavity. And then finally, here's our action shot. This is a scissors coming in and cutting at the base of a polyp to be able to remove it. We will often do this procedure under abdominal ultrasound guidance, which means that one of our ultrasonographers comes into the room and stands by your side and puts the probe on your belly. So if you wake up with a little bit of stickiness on your lower abdomen, that's the gel from the ultrasound probe. As you are recovering, when you wake up, we'll take you back to the post-op area, and usually you'll stay there for 30 to 45 minutes, giving us enough time for the anesthesia to wear off and to make sure that you're comfortable, that you could get up and get dressed to go to the bathroom while still feeling steady on your feet. And then we discharge you home. When you get home, there's some specific instructions of what's normal and what's not. It is not normal to have a fever or chills. And we prevent infection by giving most people an antibiotic called doxycycline. You want to take this with food, not on an empty stomach. And you take it for several days. If you should develop signs of an infection, it will be fevers or chills, please reach out to us. To be honest, you're more likely to get fevers or chills from COVID-19 than you are to get sick from this procedure. It's very low risk, but please reach out to us if you got COVID-19 or fever for any reason. We'll talk through what's going on and see if we need to get you evaluated. Call also for heavy bleeding. It's pretty normal after this procedure to have some light bleeding or maybe bleeding about as much as a period. And occasionally you may pass a little brown old clot here and there for several days after the surgery. Most of the time, the bleeding will last for up to a week after surgery, but it should be fairly light. If you go home and especially the first couple of days, you're having brisk, heavy, bright red bleeding, that's not normal. We want you to call us and we have you come back in to be evaluated. On that same note, when we do this surgery, we're typically not making any incisions. We're typically not making or using any stitches. But we don't want you to put anything inside the vagina for 1 week or until your post-op visit, because we do usually have to open up the cervix a little bit. And the cervix is your natural barrier against infections. It takes some time for it to close back up and protect you from getting bacteria higher up into the uterus. So no tampons and no penetrative intercourse for 1 week after hysteroscopy. Call if you're having worsening or severe pain. It usually feels like cramping, like a period coming on. And for the first day or so, it can be pretty strong cramping, like a nasty period. We want to make sure that you have plenty of ibuprofen on hand to take it home if you're able to do that safely. And you can be taking big doses of it, 600 to 800 milligrams. The over-the-counter pills are 200s, so you can take 3 or 4 of those at a time. If you do 600, it's every 6 hours, 800 every 8 hours. You can also use heat packs. We don't know if you're using it or not using it. So if you're feeling uncomfortable, you don't need to be a hero for us. We would rather you take the medications and be comfortable and be able to walk around and do normal stuff. You're going to get better faster if you're up doing normal things compared to stuck on a couch, not moving, but I don't want to take medications. Take ibuprofen. It's very safe and very effective for this type of pain. If you're taking ibuprofen and it's not touching it, you call us. Other things to avoid in the week after your surgery: showers are okay, but we don't want you to have any submersion above the waist, so no bathtubs, swimming pools, hot tubs. Physical activity isn't strictly restricted, but do listen to your body and give yourself time to rest and recover from this surgery. You're not going to be hitting your personal records at the gym. And in general, you can be doing a little bit of maybe light cardio, like incline walking, but we don't want you to be out training for marathons until you're a week out from surgery. Additionally, there's no stitches against it. There's not really like lifting restrictions, but just try not to overdo it in that week while you're recovering. The day of the surgery, it's really important that somebody else is giving you a ride home. You can't drive for the rest of the day. And we also don't recommend that you make any important decisions that day. Somebody needs to be supervising you if you're doing online shopping or gambling. Try not to stop at the casino on the way home. Try not to stop at the pet store on the way home. Most people feel really normal, but they can be a little bit drunk and have no idea. Other things to know: when you leave from your surgery, usually you're going to schedule your post-op visit with the front desk that day, and it'll happen 1 to 2 weeks after your surgery. Typically, we do it over Zoom, but if you're not feeling well, please let us know before that visit. We have you come in and see you in person to evaluate you. On that visit, we're able to show you pictures from the surgery, and we talk a little bit about any tissue that's taken out of the uterus. It goes to pathology, and we get results back after they can look at it under the microscope. So we'll review the pathology results with you as well and confirm this was a polyp, this was a fibroid. Surgery with us is very low risk, and that's why we feel comfortable doing it in our outpatient surgery center. But no surgery is completely without risk, so we have you sign an informed consent paper that goes through the following risks. Everybody that goes to sleep with anesthesia, especially if it's the first time you've had anesthesia, can have reactions that we didn't know about. If something like that should happen, we immediately reverse the anesthesia. We'll wake you up and we talk about other strategies to get the procedure done at a later date. This particular surgery is possible to have something called uterine perforation, which is kind of a fancy word of saying poking a hole in a uterus or putting an instrument through where we didn't mean to. When we do this procedure, we are looking with a camera the whole time, and so it is very difficult to put our camera somewhere where we don't know where that it's going. But this risk for uterine perforation can go up when women have had prior surgeries on the uterus or other reasons for scarred or distorted anatomy. If an instrument goes somewhere it doesn't intend to go, it can potentially cause injury to other structures like the urinary bladder or the bowel or major blood vessels in the pelvis. And much of the time, we're going to know that this is happening because, again, that ultrasound guidance. If something like that should happen, we stop the procedure where we're at. We transfer you over to the hospital where we have privileges to do bigger surgeries and where there are other surgeons available to help repair an injured structure if needed. That conversion from surgery in our surgery center to the hospital hasn't happened under my watch, and I don't intend to start with you, but I always make sure that you guys know we have a plan in place in case that worst case scenario does happen, okay? This procedure also has the unique risk of something called fluid overload. We're putting salt water into the cavity, and most of it's going to come back out through your cervix and land on my socks. But some of it will go out the tubes, and some of it gets absorbed by the blood. It's normal saline, same thing that you're going to be getting through your blood supply as IV fluids. But the body can only handle so much fluids at one time. And if you get too many fluids too quickly, that's fluid overload. We're always watching how much fluid goes in and how much goes out so that if we needed to, we stop the procedure early if there's too much fluid that we can't account for. As you're recovering, if you think of questions, things that you need to reach out to us for, typically you're going to get a call the day after surgery to just check in with you and make sure that you're okay, but also don't hesitate to reach out to us. You call the front office and ask to speak to our surgery nurse or any of the other nurses. And after hours, it's the same phone number. You'll reach the answering service who can put you in touch with a nurse or a doctor. That's my spiel. Otherwise, we'll be coming in soon to listen to your heart and lungs and go through the paperwork and answer any additional questions that you might have.